study had two endpoints. One is extension of thrombus that was happened by having the patient on low molecular weight heparins. And the other was the hard endpoint of mortality, and that was identical. So I'm questioning, do we really have hard evidence that cancer patients are so much better if they are kept on the injections once every day for 3 months?
Well, when Agnes did the subset analysis of those patients who had surgery were thought to be resectable and didn't have residual disease, she found a highly statistically significant difference in survival at 1 year between those that were in the low molecular weight heparin group, those that weren't. And there's a lot of other data too, that especially with the decrease in angiogenesis with the use of low molecular weight heparin, it goes on and on.
It goes on and on. But it's not that robust that we have to say there's no other way. We could keep them on vitamin K antagonists if there are restrictions in the budget and the money, and if maybe the logistics is not given, the daily injection is complicated. And maybe next year we will have the same discussion with the new anticoagulants. That will change anyway everything.
Right.
Joe, what's your thought on prophylaxis with respect to a person who's had an oncological problem but is technically cured to all intents and purposes? Is that a positive risk factor if they've had a malignancy that has been cured rather than being operated on for a malignant problem?
Yes, if somebody has a history of a malignancy that's cured, we still count that as a risk factor, but that they wouldn't get ongoing prophylaxis of them by itself. But most of the time that's not what we see. We see people who have active cancer, chemotherapy, ports, age, overweight, and I'm absolutely flabbergasted that CHEST blanketly recommends that we don't recommend routine prophylaxis in the cancer patient. That's a different story.
Any other questions from the floor?
My name is Joy Roy. I'm from Sweden. I just had a question about CDT on thrombolysis, and this, at least at our institution, can take 1 or 2 days to get rid of the thrombus. What kind of anticoagulation do you have during this time, and do you recommend the use of intermittent pumps during that time?
Well, we run unfractionated heparin through the sheath. Don't mix in the same bag unfractionated heparin with TPA, because you'll get some precipitation. But we run them through the sheath, and if that gets logistically difficult, at least intravenously at 500 units an hour, so it's very low dose. And then I will apply intermittent pneumatic compression to the leg being treated.
Is there any evidence for this?
Well, what kind of evidence would you like? Scientific evidence? Randomized trial? The answer is yes. Intermittent pneumatic compression will stimulate endogenous fibrinolysis. It increases venous velocity, and it decreases the propensity for intravascular coagulation, lowers activated factor VII, and interacts with tissue factor pathway inhibitor. We know that. Randomized trials on patient care and clinical outcomes, none.
Case, did you want to pass a comment?
No, just that Niels Beckgaard from Copenhagen also uses the pumps after an intervention, and he showed in his series that that was a really positive influence on his outcome.
Any other?
Don't you think you have the same results? Do you have the same results on the same exercise, just with compression stockings, and they are less expensive and are more simple to use comparing to pneumatic compression, because the results are the same.
No,
velocity.
Intermittent pneumatic compression is active, and compression stockings are just a constant compression.
Yeah.
Now, I'm not saying that they're not helpful.
Yeah,
I'm just saying that they're a difference. They're not the same.
Yeah. And I'd like to add to that that's another thing that CHEST has terribly wrong. They put mechanical prophylaxis, they put stockings and IPC and foot pumps in the same basket, and they're all different with different efficacies. And they totally ignored the Apollo trial in that regard.
Can I ask Joe, is there anything about CHEST that is good?
Yes.